Morning, everyone. Welcome, and thank you for joining us for this learning series webinar, The Intersection of Race, Culture, and the Opioid Crisis. Some housekeeping to get us started. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. And this webinar has also been approved by NJOEMS for one EMT elective CEU. So welcome all of our EMTs. We have two disclosures to share today. Our faculty member, Jason Piotrowski, discloses that he is a former shareholder of Merck and Mind Medicine. And our PA planner, Dean Barone, discloses that he serves on the Speakers Bureau of Ethicon. All other faculty and planners have nothing to disclose today. So to get started, today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME, Inc., and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to welcome our expert panelists today. We have Dr. Elisa Mobley from Virtua Health College of Medicine and Life Sciences at Rowan University, Captain Jason Piotrowski from New Jersey State Police, and Ashley Hill-Trotter, from a social work manager for Newark Community Street Team's overdose response team. And unfortunately, her colleague, our other planned faculty member for today, Solomon Middleton Williams, is unable to join us. And so without any further ado, I will turn the presentation over to Captain Piotrowski. Welcome.
Good morning. Thank you, Angela, and from everyone at Drug Free New Jersey for this opportunity to present information on this important topic. For viewers, I appreciate you taking the time for logging on as well and your interest in this topic. I am with the New Jersey State Police Office of Drug Monitoring and Analysis, and our analytical team put together this data-driven presentation I'll be delivering today. It's going to focus on demographic trends, primarily over the last few years and into 2023 with some partial data to try and give you the most up-to-date data. And it's going to be from a statewide perspective. While I will be presenting primarily data and numbers, I just want to say that we recognize that these numbers signify people, family, friends, community members, and that is not in any way, shape, or form lost upon us. You can move to the next slide, please. So the next two slides are just a little bit about our program at the New Jersey State Police. We began collecting data related to the overdose epidemic in 2013, and we develop intelligence and information regarding trends, patterns, and emerging threats. Due to our program, we were able to report and forecast the takeover of fentanyl in 2015 and warned of xylazine and through our to our public health partners as early as 2016. We pushed that information out to the media, our partners in public health treatment, harm reduction, and prevention. And we started a general monthly webinar in 2014 and one specific for our public health partners in 2018. And ultimately, we've learned a great deal from our partners and fellow stakeholders and have incorporated many of the best practices from harm reduction, prevention, treatment, and public health. And we really consider this kind of a reinvention of the public safety role. You can move on to the next slide, please. This slide just highlights the robust amount of data that we cull together and use to develop the insights and information that's going to be part of this presentation. You can see there from the slide, we have millions upon millions of records there that we use to inform our presentations and develop insights. You can go to the next slide, please. Much of this presentation is going to be comparing the degree of affliction across demographic groups. So it's an important context to understand this data. And we're just referring to the 2020 census here. The New Jersey population consists approximately 52% white, 12.5% Black or African American, and 21.5% Hispanic or Latino. Next slide, please. So this slide shows two very similar data sets, and it's the overdose death data reported by the state chief medical examiner's office in the top left there. And then the bottom right is naloxone administration data reported by first responders. So that's going to be law enforcement, EMTs, paramedics, et cetera. While we do see very similar trends, because those data sets are going to be obviously highly correlated over time, and you're seeing the decrease in total percent of incidents in the white population over time, and an increase in the Black and Hispanic populations. One side note and a limitation of the first responder data is the higher prevalence of the unknown category there, other unreported. It's likely due to the circumstances of the overdose scene, and however, it still seems to track pretty closely to medical examiner's data, which has very few unknown/other data. You can go to the next slide, please. So we're going to spend a little bit of time here. This slide's a bit of a deeper dive where we see age and reported gender information. While I have been reporting this for a few years, specifically in this venue, among others, we continue to see increases among the percent of overdose deaths and naloxone administrations among people of color, and most significantly to the Black population. While the rate continues to increase, it appears to be slowing in recent years. You can see that leveling off there, where it's going up about 1% a year. If we went back to 2015, and we were looking 2015 to 2020 or so, you would see, 2%, 3% a year, but it seems to be kind of leveling off there. Another demographic trend that we reported in the past that seems to be leveling off is the 55 and older demographic as well. When we compare the naloxone administration data, one note is that the Black population makes up an even greater percent of the naloxone administrations at 34%. And the question here, is this a good thing? And one thing that we compare this to is the data we have that shows naloxone administrations at the scene of an overdose by other than first responders. And I apologize that that graphic isn't in this presentation. It's something that we kind of put together very late. But what we wanted to look at was when and it's only going to be for law enforcement officers, when they respond to a scene of an overdose, was naloxone already delivered? And we collected about 5,000 such incidents over from 2020 through 2023 to the most recent data we have. And the breakdown shows roughly 67 to 70% of these incidents over those years involved the white population, and only 15 to 19% in the Black population, and 7 to 11% for those reported as Hispanic. And again, the limitations here are that these incidents are only derived from law enforcement encounters and not EMS, which could skew the data slightly. So I just want to point that out. But looking at it for what it is, this could indicate, less private access to naloxone among individuals and people of color who are then therefore more reliant on first responders. And when time is exceptionally important, this could make a difference. And, the good news is that this is something that can be addressed and reconciled. You can go to the next slide, please. So the next 5 slides, they're going to contain data derived from the ODMAP system, which was created by Washington Baltimore HIDA to track overdose incidents. In New Jersey, we have more than 10,000 users of the system. And for context, the rest of the country has about 20,000 users. So we have a real abundant amount of users in New Jersey that are providing data into ODMAP that gives us really good idea of what's happening in the environment in real time. And it's great that, our county prosecutors' offices have endorsed this throughout the state, and it gives us a really good idea of what's happening. So I'm going to show you what's being observed by first responders at the scenes of overdoses. So you can go to the next slide, please. In previous drug-free New Jersey webinars in reference to this topic, I was asked why we were seeing overdoses increasing in the Black population. And I did reference that this could be the result of the stimulant supply being adulterated with fentanyl. And that was something that we kind of thought was happening. And what we're seeing from the ODMAP seems to support that. First responders are reporting more crack and cocaine at overdose scenes than they have in the past. And you look at there, it's showing incidence relative to suspected opioids over time. So that red line going across there is suspected opioids. And it's a different scale, certainly, but you see the crack and cocaine numbers increasing, and the cocaine numbers are at the scene of overdoses are kind of overtaking that line there for the suspected heroin or suspected opioids. You can go to the next slide, please. Breaking down this even further, again, and understanding that the Black population in New Jersey is approximately 12.5%. We're seeing Black people involved in 39% of crack related overdoses, again, reported by ODMAP, and 27% of the methamphetamine overdoses, compared to 28% and 18% in 2020. So why this is so important is that this is potentially extremely dangerous, right? So for individuals who consume stimulants and they don't have a tolerance for opioids, sometimes people in that category are referred to as being opioid naive. Getting exposed to fentanyl can have dire consequences, obviously. And in another way, I know a lot of us in this line of work, we're cognizant of the fact that when tolerance gets lowered by people who may be incarcerated or may go through rehab, and their tolerance goes down, they're at a heightened risk. Imagine someone who has no tolerance and getting exposed to something like fentanyl. So you can go to the next slide, please. While this slide's strictly about age, certainly the trends here are important as well. And what we're going to call attention to is the significant increase of first responder reports of those under 18, specifically in the stimulant categories. And a quick note here about those age groups. They may look kind of funny there, the way they're broken down, but we often compare our data to treatment data from the Department of Human Services and NJ-SAMS, and you're going to see those on the following slide. So we just mirror those. And so when you're looking back at this, you'll be able to compare those, our age categories to their age categories seamlessly. So for all the stimulant categories from 2020 to 2023, we're seeing an increase in the under age groups from 4 to 9% for crack, from 9 to 15% for 4 to 9% for cocaine, and 9 to 15% for crack, and for methamphetamine from 4% to 17%. You can go to the next slide, please. So this slide is highlighting incidents where there are multiple victims, which would indicate a high-risk sample. And over time, we're seeing crack and cocaine involvement in overdose incidents increasing significantly from 8% in 2019 to 19% in 2023. Over that same period, suspected opioids at multiple victim overdose events have decreased from 74% of incidents to 46%. Next slide, please. And now just staying down the same path, looking at the multiple overdose incidents by race, while the overall numbers are small, we're seeing increases specifically in the Black community from 10% in 2019 to 35% in 2023. All right, we can go to the next slide. And this is just introducing the treatment data that we're going to get. Again, this is Department of Human Services and the New Jersey Substance Abuse Monitoring System. And I believe that's collected by Rutgers. You can go to the next slide, please. So this is the overall category. This is everyone that they're seeing across all drugs. And what you're seeing here is a slight decrease in white clients with a slight increase in Black clients across all drug categories. You know, it would be better if they mirrored the kind of overdose numbers more closely. I think that would be appropriate, but it's somewhat close. You can go to the next slide, please. And this one is just specifically now to heroin. And looking at the heroin-related treatment admissions, again, we see the same kind of modest trends, you know, slight increases and slight decreases across those two populations. And we can go to the next slide, please. So this is my last slide of data, and it looks specifically at crack and cocaine, and we see a slight increase for the Hispanic population. And while we don't see much of an increase in the Black population, there is that greater percentage of treatment amongst those in the Black population, 30%, again, compared to 12.4% of the population. And again, this, you can go to the last slide here. And so just to sum up, we're continuing to see increase in overdose incidents in people of color, but more specifically in the Black community. And this kind of information evidence suggests that one of the factors is that this is related to the presence of fentanyl in the stimulant supply. And it's afflicting people who may not and likely don't have a tolerance for opioids. And again, it's extremely dangerous. And that is about my time. I really look forward to hearing from the next presenters, and specifically, I've been following and really impressed with the work of the Newark Community Street Team for some time now. Thank you, and please reach out with any questions.
Thank you, Captain. Appreciate the information that you shared. And I know there's a lot of questions that are coming in the chat about your presentation. So we're just going to hold all of those until the end of all of our presenters today. But thank you again. And now, Dr. Mobley, I'll turn the presentation over to you.
Thank you. As we move forward, just a few objectives that we're going to be trying to touch on today, trying to get us to understand some of the structural origins of disparities in healthcare, recognize education as the best strategy for opioid overdose prevention, identify strategies to aid in recovery for persons residing in communities of need, and some recommendations for healthcare professionals to tackle these issues. Next slide. I would like to discuss the issues of disparities in healthcare, prevention, and recovery. Let's start with health disparity, being characterized as differences in health that are clearly associated to social, economic, and environmental disadvantage. New Jersey is the 5th smallest state in the US in terms of land mass, with nearly 9 million residents. It has the highest population density of any state, with an average of more than 1,200 persons per square mile. Jersey City, the most densely populated urban area, is located in Hudson County with over 10,000 persons per square mile. More than half of New Jersey residents are white, and 1/5, about 20%, are Hispanic. Blacks comprise an estimated 13%, or 12.5, as noted earlier, and Asians, with those with heritage that herald from areas that cover China through Pakistan, are about 10% of the population. American Indians, Alaska Natives, Pacific Islanders, and those who identify as 2 or more races make up the remaining 1.7% of the population. The next slide identifies, in 2018, fentanyl was found in approximately 30% of the overdoses in the state. Fentanyl accounted for over 67,000 preventable deaths in 2021, representing a 26% increase over the 53,480 documented back in 2020. The New Jersey CARES opioid-related indicators from 2015 through 2020 reveal the number of opioid prescriptions that were identified in the blue background had decreased over time. Despite lower rates of prescribing, opioid-related deaths identified by the red line continued to slowly rise. The New Jersey mandate for naloxone co-prescribing then began in May of 2020. The mandate was used to address patients receiving an equivalent dose of daily opioid analgesia equivalent to 90 milligrams of morphine. The mandate also was required for anyone prescribed an opioid and a benzodiazepine. These drugs, when used together, increase the risk of overdose and the risk of unsuccessful overdose reversal with naloxone. The next slide shows that despite the high incidence of anxiety and depression associated with chronic pain management, providers who prescribe opioid analgesics should avoid co-prescribing benzodiazepines to their patients. Often, attempts to revive an opioid overdose with naloxone have been unsuccessful when when benzodiazepines have also been ingested. Patients for whom a benzodiazepine therapy is medically necessary should be treated with a long-acting formulation to reduce the risk of increased respiratory depression. Next, this relationship demonstrates the relationship between where people live, that is, their residential zip code, and economic status, and how it affects outcomes related to opioid deaths in the US. Opioid overdose rates are typically higher in more densely populated urban counties. In general, urban populations tend to have higher concentrations of minorities. Additionally, persons with unstable housing or homelessness may be attracted to urban areas for greater access to public spaces and areas for shelter. The graph on the left demonstrates drug overdose death rates across the US. For all groups except non-Hispanic Asians, rates are higher in urban, noted in blue, than compared to rural counties, shown in green. Looking at the downward arrow, the greatest difference is noted between urban and rural overdose rates among populations identified as non-Hispanic Black. On the right, the graph demonstrates deaths specifically from cocaine and heroin. These are more often seen in urban counties. Heroin and cocaine are much less refined than what is typically revealed in rural counties. Heroin and cocaine are generally packaged cheaper in terms of street cost and ease of access. Deaths in the rural counties are still most often the result of synthetic opioids. However, rural population deaths overall are equally likely to be associated with refined prescription products. That is, tablets including natural and semi-synthetic opioids and psychostimulants, the type of drugs more closely associated with greater income and greater access to healthcare. The next slide, when looking at 2018 deaths by county, many of the areas of growing concern are located in the lower coastal and southwestern part of the state. It is in the areas of Atlantic Ocean and Salem counties where deaths have continued to rise despite an overall death rate for the state, which reduced from 3,199 to an estimated 3,046 between 2018 and 2020. Jersey City, our most densely populated urban area in New Jersey, in Hudson County, has a 71% non-white population, as well as a 40% poverty rate. Other densely populated areas with higher socioeconomic status, that is, lower levels of poverty, do not fall into the same risk category for opioid deaths as seen in Hudson County. The counties of most recent concern, located in the lower coastal region of Atlantic, Cape May, and Ocean counties, as well as the southwestern part of the state, covering Cumberland, Camden, and Salem counties, are generally associated with high levels of overdose rates with comparatively lower percentages of non-white residents and higher percentages of poverty. A particular concern is Cumberland County itself, which is a large minority populated area, 53% non-white with a 59% poverty rate. It must be noted that within that county are both Bayside and Southwood States prisons. Around the time of this data, persons were being released from prison with no access to transition to healthcare, leading to a return to the street and the resumption of their prior addiction behaviors. Most people returning to drug use will typically resume at their last routine dosage. Unfortunately, after a period of abstinence that can be as short as even 2 weeks, can reduce drug tolerance and readily result in overdose. Much work has been done in the past few years to transition persons into medication-assisted treatment, or MAT, upon their release, with the aim to reduce relapse, overdose, and rates of recidivism. And our final slide we see that one of the greatest tools we have for fighting the opioid epidemic is education for both providers and patients. Here in New Jersey, the currently mandated requirement for provider continuing education is 1 hour of content on prescription opioid drugs every 2 years. While this has helped, it has not been enough. In 2019, Governor Murphy allocated millions of dollars towards righting the opioid epidemic, with initiatives including prior authorization requirements that were removed for medication-assisted treatment, new Medicaid payment incentives, encouraging primary care providers to offer MAT. Residential treatment facilities were receiving Medicaid payments to provide access to MAT. There was funding for community provider access to addiction experts via New Jersey Medicaid Centers of Excellence for opioid treatment at Rutgers, New Jersey Medical School in Newark, and at the Cooper Medical School of Rowan University. The initiative also included investments in training for more primary care physicians, nurse practitioners, and physician assistants to provide MAT for opioid addiction. The School of Osteopathic Medicine provides a 2-week pain and substance use rotation to each third-year medical student, of which I am the clerkship director. Last year, our department instituted the Opioid Medical Education Program as a series of live sessions recorded with Dr. Richard German. The series focused on specific patient populations, naloxone co-prescribing, evaluation, and treatment aimed at optimal outcomes. The series remains available to providers via the Rowan University online marketplace. The Osteopathic School of Medicine of Rowan University has also been involved in strategies to enhance patient and community education. In collaboration with the Hope One Van, our osteopathic medical students have assisted with naloxone distribution, patient education, and the provision of assistance to individuals and families of Atlantic County on how and where to access MAT. There are currently ongoing discussions aimed at further reaching into the poorest and southwesternmost counties of the state, where opioid-related deaths remain greatest. This year, Rowan SOM is involved in the development and dissemination of a series of opioid grand rounds, where pain management case studies are being presented to exemplify and demonstrate the appropriate treatment and management of chronic pain, use of alternative and complementary therapies, appropriate opioid prescribing, successful opioid tapering, and the use of strategies for transitioning patients to medication-assisted treatment. This emerging program consists of a series of case-based webinars that provide examples of appropriate chronic pain management, examples of when and how to perform opioid tapering, recognizing opioid abuse even in your chronic pain patients, and identifying when chronic pain patients develop substance use disorders, and how to identify and transition those patients from their opioid analgesics to MAT when medically necessary. Thank you.
Thank you, Doctor. I know we had some questions for you as well, so we'll just hold those until we get to our next, after our next presentation, we'll go to questions and answers. So without any further ado, I will turn the presentation over to you. Ashley, welcome.
Good morning, Angela, and good morning, everyone. Thank you so much for counting it not robbery to join this most important webinar this morning on the intersection of race, culture, and the opioid crisis. I'm Ashley Hill-Trotter. I'm a licensed social worker in the state of New Jersey, and I serve as the social work manager for Newark Community Street Team's overdose response team. Next slide, please. This is just an overview that's going to kind of take us through this presentation, so we can move on to the next slide. And the next slide is actually a problem statement that our program attempts to address. We've experienced from 2000 to 2021, the investment that New Jersey's made hundreds of millions of dollars to fight the opioid epidemic. The city of Newark has some of the highest overdose rates in the state. And we've seen rising numbers of overdose deaths specifically within the Black community. Even more specifically among Black men between the ages of 45 and 64 years old, which is reflected in the population that we serve every day in our work. This population is particularly vulnerable to overdose deaths, and I'll go over why in a little bit. And despite the investment of hundreds of millions of dollars, we are still seeing a rise in overdose deaths. And we hypothesize that that's because that the investment is going to law enforcement initiatives and into treatment, which on the face seems great that it would go into treatment, but as I get into racial health disparities, we'll see why that hasn't been effective, and why community-based harm reduction programs are a really great investment and is something that our organization and others are fighting for to reduce and save lives. So reduce the amount of overdose deaths that are unnecessary. No overdose has to become fatal. So the great thing about presenting last is that I get to glean so much from my colleagues in their previous presentations. So the city of Newark is situated in Essex County, and Captain Piotrowski's slide on the 2020 New Jersey population by race indicated that Essex County is the only New Jersey county where the Black population is greater than the white population. And then Dr. Mobley had a slide where she was showing that the 2018 drug overdose deaths and the 2020 suspected drug deaths in Essex County are by far the highest in the state of New Jersey. So we're really situated in a way that we're able to see exactly how the opioid overdose is impacting Black and African-American people in the city of Newark, which again is situated in Essex County. So the population in the city of Newark is around 305,000, according to the US Census 2022 count. Blacks and African-Americans account for 48.2% of citizens in Newark. Hispanics are at 36.8% and whites are at 22.7%. The median household income in Newark is around $41,000, and there's about a quarter of people, 25.8% people that are living in poverty. Next slide, please. So I want to talk about racial health disparities in the opioid crisis, kind of from like start to finish. And this information, I have the citation at the bottom, is derived from a really great article that SAMHSA put out, or a report rather, that SAMHSA put out that strongly reflects what we see in the street, on the streets of Newark every single day, and the folks that we serve. So the health disparity actually starts prior to the misuse. There's health disparities in how the healthcare system acknowledges pain in Black people. Black people's pain reports are undervalued. Their self-reports of pain are often stereotyped by providers. A Black person can report pain at a level of an 8, and a doctor or a physician or a nurse may note it down as a 6. All of these things are reflections of racism and discrimination and implicit bias that exist. Black people, studies have shown, are significantly less likely to be prescribed opioid prescription medications for pain, despite self-reports of pain. They are more likely to experience miscommunication or misinterpretation about their pain. And because of that, their pathway to opioid misuse is less likely through the prescription opioids, as we see in the white community, that they start being prescribed opioids because of their reports of pain, and then it kind of spirals out of control. The route to opioid misuse for African Americans and Blacks more is so tied to the third point on this slide about intergenerational substance use and polysubstance use. So when a Black or African American is experiencing pain, they may not believe or have hope or faith that they can go to a medical provider and be given medication that would address that pain. But who they can go to is somebody who they know sells perks, or a family member who may be on chemo, who may have some type of pain meds being prescribed to them. And there's some sharing and intergenerational substance use going on, because due to the response of the healthcare system, Blacks and African Americans can't expect that their reports of pain will be listened to, believed, addressed, and treated with the same respect or value that their white counterparts would. So the racial health disparities start there and the root to opioid misuse. Then we've got negative representation, stereotyping, and stigma. All of these points on this slide are a direct result, effect of the war on drugs. These cannot be separated from the war on drugs. And I would even say that this was the designed effect that was intended by the war on drugs, not just to go through the criminal justice process of it, but really to have a long-lasting effect that trickles down to social services and the healthcare system. So the negative representations, they come from all of those news reports that we were seeing in the 90s on what the Black crack epidemic was doing to Black neighborhoods and what was happening in projects and Black drug dealers decimating their own communities. But we have to put these things in context. How did those drugs get there? They were planted there because Newark was a city that was heavily migrated to during the Great Migration, when Blacks were fleeing the South, fleeing Jim Crow, looking for better opportunities, looking to get away from and find refuge from racialized violence. So now you've got all of these Black people that have come up to these cities that were previously white. Newark was not a Black city. And then what happened in the 80s, 90s, their 70s, they're flooded with drugs that Blacks weren't bringing those drugs in there, but the news was capturing what the devastation was that these drugs were having on the communities. So because of this stereotyping and stigma, Blacks continue to experience mistreatment, discrimination, and harsh punishment from the criminal justice system, the social services system, the healthcare system that is intended to treat and help with recovery. So they don't often seek help because they don't believe that they're going to get it. I already talked about the intergenerational substance use and polysubstance use, and that is just common in impoverished areas that just leads into the behaviors that people have in their social networks. You have low-income communities, you have communities that are plagued by trauma, the trauma and devastation, and people are trying to survive. And the intergenerational aspect of it, how many times do we have a son who starts to become a drug dealer to bring in money for his family, and even maybe serving his own mother? That's a story that's like a constant narrative in the Black community. And he's serving his own mother because he's trying to protect her from getting anything else that could be tainted, that could be fentanyl laced. Fear of legal consequences is another issue that lends towards racial health disparities. Again, the war on drugs created this mistrust of healthcare, social services, and the justice system. With the Rockefeller laws in New York in 1973 that created severe sentencing and incarceration and harsh policies, to the Anti-Drug Abuse Act of 1986 that was enforced across the country that resulted in mandatory and severe sentencing for low-level nonviolent drug offenses. And we've got to be very careful today because there's legislation right now being passed through on criminalizing the possession of fentanyl. And while, again, on the face, it seems like, yeah, that's the thing to do. This fentanyl is out here killing people, but it's going to be punishing the same people that treatment is intended to help. People sell drugs because they're addicted to drugs. They need money to get drugs. They can't get a regular 9 to 5 anymore because they can't handle that due to their addiction. So they start selling drugs, and now they're trying to, again, keep the war on drugs going. So men fear going into treatment because they think that they're going to be incarcerated. Women have the same fear, but they also have the added fear of having their children removed and placed into the foster care system if they acknowledge that they have a substance abuse problem. There's also misperceptions and faulty explanations about addiction and opioids. People in the Black and African American community still view addiction as a weakness and not a disease. That disease model has not yet gotten to the point that the white community has accepted for it. Black people will say this is a moral failing. They'll say that about themselves, about their family members. And then there's also a lack of culturally responsive and respectful care, implicit biases in the healthcare system, failure to bridge the racial cultural divide, and a lack of even Black or African American practitioners who treat the disorder. So people can't even go into healthcare and see someone that looks like them. So I just want to go through a few slides that describe how our program was designed to be a response to the war on drugs. Can we go to the next slide? We actually went to the community and asked them exactly what they wanted. So these are just a few demographics of the 430 folks that we surveyed. And we wanted to know exactly what they wanted in an overdose response that would help them save themselves. Next slide, please. Next slide, please. Oh, I'm sorry. I was actually looking at the wrong screen. So we had 85% of people that said that 911 was helpful, but the primary reason that people did not find it helpful was due to the length of response, and people experienced others dying while they were waiting for 911 to respond. Next slide, please. And we held focus groups, and these are some of the quotes that we took from the focus groups, where people were sharing what their experiences were like when they contacted 911. And it culminated in the need for a more compassionate response without fear of arrest. People were not calling 911 in the event of an overdose because they did not want to be arrested. The Good Samaritan law, people weren't aware of it. The police, how much training do the police get on the Good Samaritan law? So the next slide is going to show how we responded to what we learned. We developed a community-based non-law enforcement first responder program that sought to reduce fatal and non-fatal overdoses, reduce health and social harms to people who use drugs in their communities, improve the use of harm reduction services, and reduce arrests associated with overdose events. So the way our program is modeled, and we have pictured here, we have a team of 2 outreach workers who go out twice a week with 2 university hospital EMS workers, and together they co-respond to overdoses, and they respond and they assess what's going on with the person. They administer Narcan, and then they offer care coordination services that I oversee. So if people want to, seek treatment, if they need help navigating the healthcare system, if they need help navigating the social service system, if they need assistance with housing, we assist with all of that. Next slide, please. And the next slides that I'm going to go through just depict the results. We've been operating in this program since May of last year, and to date, Our overdose response team has responded to 76 overdose calls. 42 of those have been opioid overdose responses with University Hospital. Now they get a lot of calls and not all of them are for opioid overdoses. So it seems like about half, more than half were for an actual opioid overdose. People receive care on site from the EMS worker. They receive transportation. Of course, our team encourages everyone to go to the hospital after reversal of an overdose, but that's not always what people want. So we do try to offer them services and follow up with them in the aftermath. Got 12 people that said no, they don't want to go because some people are just trying to get to their next high. It's an embarrassing event. Some people just want to get away. And again, people are fearful of arrest. And we've had 20 people consent to follow up and working with our care coordination services, mostly people seeking treatment or housing. But the best number on this slide is that for all of these 42 responses that our team responded to as an opioid overdose, no one was ever arrested, which is great to me. Because now we know that people have more faith that they can call 911 and get medical assistance without fear of overdose. Next slide, please. I am so proud of our outreach workers for the amount of harm reduction supplies that they flood the street with every single week. As you can see, in a year's time, we've distributed over 5,000 harm reduction supplies from intramuscular naloxone to intranasal Narcan, to fentanyl test strips, to safe sex kits, to wound care kits, to PPE such as masks and hand sanitizer, to compression socks, to sharps disposals, including fit packs that are very discreet black boxes that you wouldn't even know what it was if you are not an intravenous drug user. And we also give out sharps containers, the red ones, whether it's 1 quart or 3 quart. And getting these supplies in the hands of people who are most likely to need and use them has been incredibly impactful. Just this week, when our team was out with University Hospital, we learned that one of the main hotspots when we started this work was Freeling-Heisen Ave, which is kind of like an industrial area, but high level of drug use and high level of overdoses. And just this week, University Hospital let us know through their mapping that that is no longer a hot spot for overdoses. Why? I would say it's because our team is out there nearly every week flooding that area with Narcan. So is there still drug use in that area? Yes. Is there still a high amount of drug use in that area? Yes. But what is the difference? The people who are using the drugs have the Narcan to reverse the overdoses themselves. So we were really happy and pleased and excited about that. Next slide, please. This just describes our care coordination service trends. We've enrolled 27 individuals in our care coordination services since we've started. And this just depicts the breakdown of the needs that we address. As you can see, by far, most people are most interested in addiction treatment, and that is based on the population of people that we serve. Like I said, we serve an older population of Black folks, and I'm talking, we don't really have anybody younger than 45. And most people, they're not new to this, they're true to this. They've been using for decades. They've been using for 30 plus years, but the supply of fentanyl is really creating a problem. And people are now like, okay, like something's got to give because I can't keep using and overdosing every time I use. Like it didn't used to be like this. And they see their friends and their family members dying. I have people on my caseload that are calling me, telling me that their sister just passed away from an overdose and they're using the same drugs as her. So now they're seeking treatment because they recognize how unsafe the supply is and that they can't outrun it and they can't out-trick the supply. Next slide, please. And this 21% has just kind of our smallest needs that I broke down so we could see them a little bit clearer. But next to addiction treatment, housing has to be the next highest need. And thankfully for our funder, we're able to provide housing to folks and further assist them. And we see that the housing first model is definitely like not a joke. Like it really works and it really makes a difference, especially for someone who's going into or coming out of treatment. And we can go on to the next slide, and that brings me to the conclusion of my presentation. But thank you so much.
Thanks so much, Ashley, and thanks to all of our presenters today. I know we have a number of questions, and because we have about 10 minutes, we're going to launch the poll now. So I appreciate if anybody can give us some feedback on today's presentation. But I'll go with the first question, and I'll start, Dr. Mobley, with you, and then we can go Ashley, and then Jason, if you have something to add to it. But can you speak to how the health disparities mentioned today impact the work that you are doing, and from your perspective to address the opiate epidemic?
One of the things I wanted to mention first, because it seems to be a thread through the questions that come up, has to do with the focus on poverty. I do believe that this is the primary focus, but what needs to be understood is that when we talk about racial disparities and when you talk about structural racism, those are the things that leave people trapped in areas of poverty or leave people socioeconomically impoverished. And the poverty keeps you from having access to health care. It keeps you from having access to Narcan. It keeps you from having access to the types of services that you need to get yourself out of addiction. So for those who were concerned or who were focused on poverty, yes, indeed, that is an issue. But if you look at how people get structured or funneled into poverty, the zip codes where the poverty exists, that's where you find what we call the racism or the racial disparities. And now I'm going to ask you to repeat the question.
No problem. The question was, how do those health disparities that were mentioned today impact the work that you're doing to address the opioid crisis, or people within your field?
Yes. We do here at Rowan University, we recognize those disparities. We take a lot of our Medicaid patients as well as our regular insurance patients. We have mental health facilities right here in our practice. So for those patients who have an opioid use disorder, we try to get them into working on therapy with a licensed social worker. We try to get them the medications they need through our mental health APN. We recognize the whole picture of what goes on with these patients. The hardest thing to get people outside of opioid addiction to understand is that the opioid addiction hits the same mu receptors in your brain that have to do with depression, that have to do with anxiety, that have to do with that low self-esteem, that low self-worth. So when people are impoverished, when people don't have medications or services, when people feel really bad, it's the same type of pain as if you broke your leg. And that pain registers in the exact same place in your brain. So whether you're taking prescription pain medication or you're using heroin, you're trying to get rid of the same pain problem. That's why people use opioids. That's why people are attracted to opioids. It has to do with the pain that they have, even if it's just what we consider mental anguish. If there's nothing else to fix it, the opioid fills the void.
Thanks, Doctor. And Ashley, good to see you. Can you comment on that, on how your work is impacted by that? I know you touched on it, but is there anything you can add?
Advocacy. I am like constantly on the phone with providers, advocating for the folks that we serve and identifying the barriers and like ratcheting that up to management, because what I find is there is a stark disconnect between what leadership is purporting and wanting and like saying is happening and what is actually happening with that frontline staff. So I'm documenting, I'm emailing, I'm calling, I'm talking to the head of the organization, I'm talking to the program manager, and I'm explaining this was the experience, this was the user experience that this individual had. For instance, a mental health provider, substance use provider was scheduled to do an intake with one of our participants. Now, this participant was on probation, so they had to get community approval to even be out like in the community. They had to get transportation to get there, and they arrived 11 minutes late to their appointment. And the provider refused to see them. And I said, wait a minute, you guys are serving a population that is seeking mental health treatment and substance abuse treatment. And you're that inflexible that you are going to cancel this individual's appointment who's in need of psychiatric medication and evaluation. And I had to talk to the program manager and explain this is like what happened. And she was like, yeah, that's unacceptable. And that's not how we train our staff. So again, it's a lot of advocacy and documenting and talking to people and sharing what is actually the experience that is happening at these frontline interactions, and hoping that they train their staff and their whole organization around being anti-racist and creating policies and procedures that actually work for the communities and populations that they're trying to serve.
All right, great. So education and advocacy, great tips as well. And so Jason, not sure if this impacts as you're doing data collection. So we also have a question for you on, you mentioned suspected stimulants are being determined on scene. Can you just speak a little bit, clarify that a bit?
Yeah, sure. So the officer perception of what he's looking at when he responds to the scene, the drugs are, they don't change very much in presentation. So he's going to look at the type of packaging, what the drugs actually look like. And there also could be, if the victim is conscious, they could tell him what they were taking, or, other bystanders could, who were present at the time could tell him as well. But those things, a police officer knows what crack looks like. A police officer knows what methamphetamine looks like, et cetera, et cetera. So generally, or the packaging associated with cocaine versus opioids, they're generally very accurate. So while it's not 100%, it's going to be very close.
All right, thanks. And Dr. Mobley, this is a question for you. We have a question from a nurse. Implicit bias can be an issue in healthcare settings, as has been touched on today. In what ways can we improve training for healthcare professionals to recognize implicit bias and to work to prevent it?
One of the things that we do here, that I personally do here with our medical students, is to simply point it out, because it's very hard to know what you're doing wrong when it's been your learned experience to do it that way since day one. So internally, you don't see anything wrong with it. The problem is many of us do not speak up, do not help each other learn what to do or what it is that we are doing. It's no different than if you're a young woman and you twirl your hair. You don't want to twirl your hair on the video. You don't want to twirl it when you're giving a professional presentation. But if no one ever mentions to you that you do that, you may find yourself twirling your hair in exactly the wrong circumstance. It's the same concept. We all learned what we lived. If we all watched the same television shows, if we all saw the same commercials, if we all went through the advertisements regarding the war on drugs in the 1980s and 1990s, then we all started to believe the things that were being thrown in front of us, whether they were true or not. And because we all live in our own little situations, circumstances, zip codes, we don't bother to find out what reality actually is, which is one of the reasons why diversity in the workplace makes for a better workplace, because all of a sudden you may find out how small your world has been and how larger the world actually is, which is where advocacy comes from. When you realize that there are people in high places who don't get to see the entire foundation of what it is that they're leading. It's the same reason with our state police officers and with our local police officers. They only have so much information. They're only told and taught so much. But again, we all learn what we live. And unless and until we expand that, we're not going to make a whole lot of progress. But the idea is to expand it in as many ways as possible. One of the commenters had mentioned education, more CMEs was not enough. It was get rid of the illicit opioids. Everything has to be done. If there is no one silver bullet, there is no one answer. We have to work at this from all angles because, again, we have all learned to live this way and we have to learn something new.
Absolutely. So just echoing what you said, I appreciate all of our speakers today. I know we're at the end of our time, helping to expand, right, that world and that knowledge and those experiences with all of us who are on here today. If we just have, want to just take a minute, I'll just start, Jason, with you. We'll just one last comment to leave with our attendees today.
I agree with the doctor here. There's not one answer. And, you know, for New Jersey, we've been doing fairly well. And I'll just throw this out there from 2018 to 2021, the rest of the country in overdose deaths is up like 60%. And during that time, you know, we went down in 2022, down 7.5%. We're trending down. So, but it does take a lot of different perspectives and, you know, a lot of different help in the community, harm reduction, prevention, treatment, and law enforcement, obviously, you know, all have to be working together and many more to get this done.
All right, thank you. And thanks again for your presentation and for all law enforcement does to share this information with all of us on here today. I know the research that you've been doing and sharing. And Ashley, I'll go to you next.
So I think my final thought would be to everyone as, you know, folks who work in the healthcare, social services, criminal justice industries. I just have a question. Do you want to be a soldier continuing to fight for the war on drugs? Or do you want to be an agitator fighting against the war on drugs? The choice is yours in every interaction that you have with a client, patient, participant. It's in every action. So I would implore you to think of the racial context of the folks that you're serving and the history that brought us to this point. And I encourage you to research the origins of the war on drugs and why there is now a movement to decriminalize drugs, because it is very race-based. And it was based on who was using the drugs, not on the drugs' effects, but who was using it. So please keep that in mind in all of your interactions and in all of your service provisions.
Thank you, Ashley. And thanks for being with us today and sharing and all the work that you and your team do to help save lives. So significant, everything that you outlined. So thanks so much and for your call to advocacy. And Doctor, we'll end on you. Final note for today.
Note is to be a little bit more compassionate, to understand that emotional pain is as bad as physical pain, and people will seek solutions to their pain, whether they have access to healthcare or not. So we need to do a better job of being compassionate. We need to do a better job of making sure people have access. We need to do a better job of understanding people and how where they're at that moment affects their interactions with you. So a lot of times our perception of the person has nothing to do with what's going on. And we need to take a moment to be a little more compassionate and find out what the root cause of that behavior is, instead of using our lived experience to label that behavior as discriminatory, as drug seeking, as whatever it is that comes to mind.
I think that is a perfect note to end on and can apply to all of us who are on today, right? Whether we're in a medical setting, in the community setting, law enforcement setting, prevention, treatment, all of us, that's just a great lesson for us all. So I thank you for sharing that. Again, I thank all of our panelists. I thank all of our attendees. I know we went over a little bit of time, so I appreciate everyone sticking with us. Information is on the screen on how to get any of those credits that I mentioned at the beginning of the presentation, as well as information on our next webinar that's going to be held on July 27th, Public Health Barriers in Addressing the Opioid Crisis. And I hope that you can join us. I wish everyone a wonderful Independence Day celebration, and hope to see you next month. Have a good day, everyone.